I mentioned before, we have missions of excellent and exceptional, I say world-class, equitable and inclusive patient care, as well as research, laboratory, translational research, and clinical trials, and education. And I think today's event is a testimony to our commitment to education, not only to the providers and medical teams, but also to the patients. We're going to cover the entire spectrum of urinary tract cancers, bladder and upper tract urinary tract cancers, and cover different aspects of care, different parameters of care, which I think is important. And we did this event live, face-to-face, about 2 years ago, and many of you were present. And because of the pandemic, we couldn't do it last year, but we're back this year, at least virtually. And we hope, when it's safe and possible again, to do that in person, hopefully next year, if everything goes well. In the context of this interactive and multidisciplinary care, I will tell you that we cover multiple different things, and you see an agenda which is all packed today. We have 2.5 hours of activities, and we're going to do serial introductions with Dr. Wright of the speakers, and as you see, multiple different topics, and we're going to end with the breakout rooms. And participants can select which breakout room they would like to join. At the end of the whole meeting, I would like everybody to come back in the main room in order to have like a few closing remarks by Dr. Wright and myself. And the other thing I would say for housekeeping, and Dr. Wright will go through this, is to make sure you guys are muted, and if you have questions, post them in the chat room, but I would try to avoid posting in individual patient care questions. You know, it will be difficult to answer all of them in the context of this meeting. With that note, I would like to pass the microphone to my great friend and colleague, Dr. Jonathan Wright.
Thanks, Dr. Grivas, and thank you everyone for being here. We'd much rather be in person, but I'm just glad we can still put this together. Obviously, there will likely be some challenges electronically, as we're already seeing a bit, so be patient with us and as well too. So in the spirit of the multidisciplinary care that Dr. Grivas highlighted, our goal really is to have a breadth of different speakers today, and our main goal clinically is to help find the right treatment for you, and we're hopeful that you can also find some useful information today, no matter what aspect or stage of the disease you're at today. So this is going to be recorded for those that aren't able to participate today in person. You can see about the microphone. We'll try our best throughout today. If you want to turn your video off, that's great. If you want to keep it on, it's totally up to you. And if you happen to pop out, you can pop right back in, and we'll get you back into the meeting. And we'll explain how we're going to do the breakout sessions a bit later. You know, our work that we do would not be possible without our supporters and our two sponsors today that are here. And I'm going to start out by talking about Howard. So Howard is a bladder cancer survivor as well. I believe he's about 8 years out now from his original diagnosis, went through 3 years of treatment and continues on monitoring to this day. About 7 years ago, he decided to start a foundation, the Howard J. Cohen Bladder Cancer Foundation. And one of the goals of that was to raise money for bladder cancer research. And during the early phases of our research bladder cancer program here, it was funds from the Howard Cohen Foundation that allowed us to continue and maintain some of our most important research efforts. We have a program that'll be talked about a little later, where patients who pass from bladder cancer will allow us to do a research autopsy to collect some of these spread tumor spots for us to do research on. And this is obviously a tremendous, generous donation of the individual, but it takes a huge team to do this. And the resources are significant as well too. And it was Howard's support that allowed us in the early years to make this a reality, to where we're now much more self-sustaining with this. So I want to turn it over to Howard to say a few words, thank him for what he has done and what he continues to do, and congratulate him on his survivorship. Howard.
Good morning. Thank you for inviting me. As Jonathan said, it was a little more than 7.5 years ago that I got diagnosed, and friend of mine and I decided to start this Bladder Cancer Foundation. There's three legs to the foundation. One is awareness, bringing awareness to the public about bladder cancer and the need for funding for new research and new medicines. When I got diagnosed, I was treated with BCG, which is the same drug they've been doing for 20 years. And so hopefully this new research that they're doing will be able to bring medicine and medication and treatment to the forefront. The second area of the foundation was living a healthy lifestyle, and several different doctors, including Jonathan, suggested that I follow a plant-based diet, which I have followed religiously for all of the 7.5 years. And the third, of course, is raising money for research. I have traveled as a Rotarian around the world to Brazil, Korea, Canada, Germany, and the United States, and will continue to do that. And each year have a booth at the Rotary International Conference where I meet with tens of thousands of people and share my story and hear their stories, no matter what cancer they have, bladder cancer or whatever. It's a matter of attitude and caring that gets through it all. And I have found that being vegan has helped me and many, many, many others. It's really a matter of survival, and it's been great. We've done golf tournaments over the past 6 years. We didn't have one last year. Are not planning one this year due to some logistics, but we'll be back next year in July. And we've done some major fundraising with that, and would love to have you partake in that. So thank you again for inviting me, and best of luck in this program.
Thank you so much, Howard. Thanks for all that you do. We're going to move ahead to our first speaker, and it's one of my colleagues and partners, Dr. John Gore. Dr. Gore went to Baylor Medical School, did residency in urology and a cancer fellowship at UCLA, joined the University of Washington over 10 years ago now. He and I started at the same time. He's the Bridges Endowed Professor in prostate cancer and urologic research. And he runs or is co-chair of a national study, and he'll probably talk about it in his discussion as well today too, that is focused on patients with non-muscle invasive bladder cancer and the treatment decisions that they have. So we are lucky to have him here today, and I'll turn it over to Dr. John Gore.
Thank you so much. Thank you, Jonathan. Thank you, Petros. Thank you, Howard. I love being a part of this meeting, and I love the mission of this meeting. And so it's a pleasure to get to talk with you this morning. I'm going to focus on non-muscle invasive bladder cancer, and the goals of this are to talk about how we diagnose bladder cancer, how we pursue initial treatment of bladder cancer, and then what's really a conundrum, not just for patients, but also for doctors, how we treat cancer when it fails sort of our first line treatment that Howard was just talking about, BCG. These are my disclosures. They're all research funding disclosures. So how do we diagnose bladder cancer? Well, in the urinary tract, in the urinary system, our three common cancers are each diagnosed in different ways. So prostate cancer is most often diagnosed based on a screening test, a PSA blood test. Kidney cancer is most often diagnosed because it's picked up on an X-ray for another reason. But most bladder cancer diagnoses are made because someone has a symptom, and the most common symptom is blood in the urine. And this is a campaign, a See Red campaign that's also been in the UK, but that's sponsored by Bladder Cancer Canada, just to raise awareness about the importance of hematuria and how it can portend a bladder cancer diagnosis. And as all of you are aware, the next step after we hear that someone has blood in the urine is we do a cystoscopy. So a cystoscopy is where we look in the bladder, and cystoscopy has incredible visual specificity. You know, that's why oftentimes your doctor will tell you that they're pretty confident that they saw a, because visually what we see is very specific for cancer. There are some new and novel ways that we can make these diagnoses. And so one of those novel ways that we have at the University of Washington and Seattle Cancer Care Alliance is blue light cystoscopy. This is a fluorescent cystoscopy where before your procedure, the nurses in the pre-op suite will put a fluorescent dye into the bladder called hexaminolabulate. And then in the operating room, we can use a blue light, and you can see that cancer fluoresces as bright pink. And so what this allows us to do is this allows us to see things that, sorry, can you not do that? I'm sorry. Sorry about that, everyone. So it allows you to see not just things that are visible under white light, but it allows you to see things that are not quite visible to the naked eye. And it's been shown that this blue light cystoscopy increases our ability to diagnose more cancers than just regular white light. And it's been associated with a decrease in recurrences for people with non-muscle invasive bladder cancer. When we do diagnose it, we try to assign it to one of these risk categories. And this helps us talk about prognosis. You know, what is the likelihood that this cancer comes back? What is the likelihood that this cancer becomes a worse cancer? And it also informs how we treat non-muscle invasive bladder cancer. And so low risk bladder cancer, which fortunately is the most common type, is where the cancer is low grade. And that means that under the microscope, the cancer cells look more like normal bladder cells. They look like they're not dividing rapidly. And it also means that this cancer is confined to the inner lining of the bladder. So what I'll often say is it's more like a polyp. Like, you know, if you hear about a colleague or a friend that has a polyp in their colon, that's not as alarming. And low risk bladder cancer tends to behave more like a chronic disease. Intermediate bladder cancer is where either that low grade cancer is big, or there are multiple of them, or it's coming back, or a very small high grade cancer that's still just confined to that inner lining of the bladder. And then high grade non-muscle invasive bladder cancer, which is the one that we're most concerned about, is where either that high grade small cancer confined to the inner lining is coming back, or it's larger or in multiple areas, or it's a more aggressive cancer that's invading through that inner lining into the second support layer of the bladder. And that's a tumor stage T1 non-muscle invasive bladder cancer. And then there's this entity called carcinoma in situ. And when you hear about in situ cancers that are, for example, like in situ skin cancers, we think of those as precancers, but in the bladder, this is cancer. And it's a flat cancer of the inner lining of the bladder. And so that's considered a high grade or a high risk non-muscle invasive bladder cancer. And like I said, those risk groups, they inform how we think about prognosis as well. So in general, a low risk bladder cancer is one in which we're going to do close surveillance, you know, and that means monitoring with cystoscopies on a semi-regular basis. For an intermediate risk bladder cancer, we're going to consider treatment with BCG. And so this is a bladder treatment that you get initially once a week for 6 weeks, and then you get maintenance treatment for up to a year. And then for a high risk non-muscle invasive bladder cancer, because we're concerned about it coming back, and we're concerned about it coming back in a more aggressive form, we give you that maintenance treatment for 3 or more years. And so you can see that that risk category is associated also with the intensity of the treatment that we would deliver. Now, when we first diagnosed bladder cancer, because of these risk categories, we're able to slot it into sort of an algorithm of treatment. Where we really have challenges is when the cancer comes back, where it fails BCG. You know, the cancer has shown itself to be resistant to BCG. And this is difficult because, you know, still for 40 years, the first line treatment has been BCG, but what we give in the second line, it's highly variable. And the success rates of these treatments is also highly variable. And we have these different definitions for how we define cancer that has failed BCG. You might hear about BCG refractory non-muscle invasive bladder cancer. That usually indicates an early, more aggressive recurrence. BCG relapsing non-muscle invasive bladder cancer, that's where it seemed like we were successful early on and then it comes back later. There are some patients who have a really challenging time tolerating BCG because it has a number of local effects on the bladder and some constitutional effects. And so here the bladder cancer persists in part because we're not able to deliver sort of our best BCG dosing. And then we kind of combine BCG refractory and relapsing non-muscle invasive bladder cancer into this category that's now called BCG unresponsive non-muscle invasive bladder cancer. And in general, when you ask experts what we do with these cases where the cancer has failed BCG, well, if it's for this carcinoma in situ, we try another round of BCG. But because we are concerned that when it comes back and when it shows itself to be resistant to BCG, for other types of cancer, we tend to avoid repeating BCG. We tend to avoid it. This is an arena where we try to be actively involved in clinical trials. And Jonathan Wright has led numerous clinical trials at the University of Washington and SCCA for just this exact clinical scenario, because we want to stay on the cutting edge and we want to offer our patients the best available new treatments, but we also need to figure out what works better than our existing treatments in this clinical space. And then importantly, when it's still confined to the inner layers of the bladder, we still think this is a curable cancer. And we don't want to miss out on that window of cure. And so your doctor may strongly consider bladder removal, even if the cancer hasn't gotten into the deeper layers of the bladder, because we worry about it coming back in a more aggressive form. And so it's not uncommon to offer bladder removal surgery or radical cystectomy in situations where the cancer has failed these BCG treatments. Now, what we sort of prefer to use in this clinical space is highly variable. So Dr. Wright mentioned that I'm co-chair of a trial that takes place at 28 sites across the country. And as we were thinking about planning our trial, it's for these exact patients in whom their cancer has failed BCG treatments. We asked doctors across the country a couple years ago what their preferred treatment was, what their preferred salvage therapy was. And this isn't meant to go into detail about what the different therapies are. This is just meant to appreciate that this is an area of tremendous clinical uncertainty. And you can see that different sites and different experts use vastly different treatments. And one of the things to highlight is in the dark blue, you'll see that a lot of sites, the preferred treatment is a clinical trial. And that's just a sign that we still don't know what the perfect treatment is in this salvage setting. There are some things that are more commonly used, like a combination of two chemotherapies called gemcitabine and docetaxel. And then more recently, there was an approval of an intravenous medication called pembrolizumab that has some good response rates. And it appears that in those patients that do respond, that response tends to be durable, meaning that they tend to keep that response for at least a year or more. So if they do respond, that tends to be something that is sustained. I did mention bladder removal surgery, and the reason that we prioritize it for some patients is that it works very well. The cancer-free survival of bladder removal surgery for BCG unresponsive non-muscle invasive bladder cancer is very high. It says here below 80 to 90%, but there is a more recent paper that I just found last night that had a 5-year survival rate of 92%. And so in general, this is something that we do strongly consider. But it's hard to make that decision. It's a big surgery. It's a morbid surgery. It's one of the very few cancer surgeries where you're not just taking something out, but you're replacing it with a reconstruction. And so we sought to better understand this decision and this comparison. And so the study that I run has the best acronym of any study I've been a part of. It's called CYSTO. And that CYSTO stands for Comparison of Intravesical Therapy and Surgery as Treatment Options for Recurrent Bladder Cancer, CYSTO. And what we're doing is we recognize, and patients told us this, that this is not a situation where a randomized controlled trial is the right thing to do. And it's because overwhelmingly patients told us that they wouldn't subject themselves to the flip of a coin when it came to bladder removal or more conservative strategies into the bladder or into their vein. And so instead it's an observational trial. And what that means is patients and their doctor teams choose the treatment, and then we follow them very closely, not only to capture their clinical data, but also patient reported outcomes like quality of life, urinary health, whether or not they regret their decision, how their cancer treatment impacts their financial wellness, and also how often they're using healthcare services like emergency departments and hospitals. So this is a clinical space where the diagnoses are fairly straightforward, but the treatments can be hard and the decisions can be challenging. But hopefully that gave you some overview and some guidance for how we diagnose and treat non-muscle invasive bladder cancer. And I'd be happy to take any questions.
John, thanks for the outstanding review, and it's exciting to see new options becoming available too for patients, and look forward to those results from your study as well. And please, anybody have any questions, type them in the chat. We'll try to get to them as we move along. Dr. Gore, one question that commonly comes up, and looks like actually the first question popping up is along the same lines, is, we have these new treatments coming out, but the standard that Howard talked about, BCG, has certainly had a shortage. And how do you help counsel patients who are dealing with or facing the shortage?
So, I mean, that's a challenge that we have had to navigate on a couple of different occasions. And I will give full credit to Dr. Wright and how we as an institution manage the shortage. We were slightly more insulated against it than other sites, but we still had to make decisions about how we treated patients. And this is where, we had our own internal systems for how we made decisions about BCG, but our organization, the American Urologic Association, also pooled together a bunch of bladder cancer experts to come up with some best practices around BCG. And one of the things we did was for higher risk individuals, we at least got them through the induction treatment. And that way we were able to at least get them the best available treatment as the first available treatment. And then decisions about ongoing maintenance BCG were made in part in a way where Dr. Wright assembled sort of a team of our local experts to make decisions about how to best allocate our BCG. We're very fortunate in that shortage has largely resolved locally, but unfortunately we are always at threat for BCG becoming short again. And I see a question about gemcitabine as well. So gemcitabine is a chemotherapy that we give into the bladder. And in general, gemcitabine is much more well tolerated than BCG. It has been compared head to head with BCG for high risk cancers, and it's not as good in that setting. But where we use it a lot as the first line of treatment is in lower risk cancers that are more burdensome. So there are multiple of these tumors in the bladder, or they're bigger. And we feel like close follow-up just isn't enough. And I know that for myself, and I believe for you as well, Dr. Wright, that gemcitabine is the preferred treatment in that scenario now more than BCG. We also give gemcitabine right after we do a bladder resection. We worry that the resection itself may aerosolize small microscopic cancer cells that could implant elsewhere in the bladder. And we know that giving an immediate treatment with chemotherapy reduces the chance of it coming back, and gemcitabine is the preferred drug for that.
Great. Well, I think we can go ahead and move on to our next speaker. I'll turn it over to Dr. Grivas. Thanks again, Dr. Gore.
Thank you.
Thank you so much, John. And thanks again, Howard, for your wonderful presentation. And I just want to say that it has always been a pleasure to work with Howard and Dr. Wright in many events that Howard is organizing. And he actually put a very nice message in the chat room. Howard is always an advocate of early recognition of symptoms. So one of his pet peeves is make sure when someone sees blood in the urine, see your doctor, don't ignore it, which is important, especially in the area of COVID, the pandemic, how much delay of diagnosis we see when patients do not do their workup. So that's a great message. With that, we'll move forward to the next speaker. It's my great pleasure and honor to introduce my great friend and colleague, Dr. Bruce Montgomery. Dr. Montgomery is a professor in the Division of Medical Oncology at the University of Washington and a full member in the Clinical Research Division at the Fred Hutchinson Cancer Research Center. He's a very experienced medical oncologist, has treated genitourinary cancers and has made vital contributions in the field. Bruce, thanks for joining us.
Thank you, Petros, and thanks to everybody else. I think actually, I don't know if Jonathan Chen is ready to present or not. I think we talked about potentially sort of flipping the sequence.
That's right.
Make it make sense. Jonathan, are you ready for that?
Yeah, I'm here.
That's a good point, actually. Thank you, Bruce, for this reminder. Actually, we decided to change the sequence because Bruce will talk more about advanced disease. So I will introduce Jonathan, Dr. Jonathan Chen first. Dr. Chen is an assistant professor in the Division of Radiation Oncology at the University of Washington. He's an assistant professor at the Clinical Research Division at the Fred Hutchinson Cancer Research Center. Dr. Chen is a great colleague and we work together treating multiple patients right now. And he's also part of our multi-specialty interdisciplinary clinic that happens every Tuesday morning at the University of Washington. And he also has a clinic at Seattle Cancer Care Alliance. Jonathan, thanks for joining. I love your background. You can take it on.
Thanks, guys. Thanks, Petros. And hello to everyone. It's really exciting for me to be here this morning with you all. I think I get to share screen. Is that right? Let me see if I can.
I think you can, yes. And ready to.
That is correct. You can share your screen.
Okay, can everyone see that?
Yes.
All right, great. All right, everyone. So again, I'm Jonathan Chen. I am in the Department of Radiation Oncology here at UW and SCCA. And so what I'm going to talk to you guys about today is diagnostic and treatment options in bladder cancer that is muscle invasive. So Dr. Gore just gave us a great talk about treatment options when the bladder cancer has not yet invaded the muscle. And so when it has, what do we do then? I have no conflicts of interest to disclose. And so again, majority of bladder cancers that are diagnosed are actually non-muscle invasive, somewhere between 70 and 80% of them. And so for those, we talked about with Dr. Gore, what we do for those patients. But what happens if I or you or one of the other 20 to 30% who has muscle invasive bladder cancer? Now the big distinction is kind of a big red line that differentiates non-muscle invasive and muscle invasive. And it's all based on how far through the bladder wall the cancer invades. And so when your urologist goes in with a cystoscopy as part of your staging and evaluation for your cancer, they'll do a biopsy or a resection of the tumor called a TURBT, a transurethral resection of bladder tumor. And then these specimens are kind of analyzed under the microscope. And a pathologist looks at how deep does the cancer invade through the various levels of the bladder wall. You can kind of see in this depiction here, there's a couple of different stagings that are on the left of the red line. These are all considered non-muscle invasive. They're not yet going through the big pink band, which is the muscle layer that you see in this diagram. Anything that's invaded into or even through the muscle layer would be considered muscle invasive. This automatically makes you at least a T2 or a stage 2 bladder cancer patient. And it's those kinds of patients we're going to talk about now. And so in the fight against bladder cancer, what are the treatment options that we have? And I often think about it as there's a three-pronged approach that we often take. Now, there are other arms as well that help us in medicine to treat cancer patients. But the big three are kind of surgery, medical oncology, and radiation oncology. They apply different treatments in different types of cancer. And for each cancer, it depends on your stage and the type of cancer to determine what the best available treatment options are for you. So when we're seeing a patient who's been diagnosed with muscle invasive bladder cancer, the first question that we ask is, are you a candidate for surgery? This question has kind of two distinct aspects of the question. One of them has nothing to do with characteristics of the cancer at all. It's more of a question about you as a person and as a patient. Are you able to safely undergo any surgery? The risks of the anesthesia and the surgery, are you healthy enough? Do you have other major illnesses like heart disease, lung disease, or are you able to go through a major surgery? The second part of the question is specific to your bladder cancer, and that's, does your cancer appear to be one that can be safely resected or removed with surgery? That's often something that we base on what we see during the cystoscopy and also what we see during the imaging scans that we do as part of your workup of your bladder cancer. Now, if the answer to both of these questions is yes, then the standard recommendation for treatment of muscle invasive bladder cancer is centered around surgical removal of the bladder. The second question we then ask is, are you a candidate for chemotherapy? Do you have certain conditions that might put you at higher risk for some of the bad things that can happen with chemotherapy? Do you have good performance status? Meaning, are you relatively healthy and active? Do you have certain things like neuropathy, hearing loss, impaired kidney function? Questions that your medical oncologist will ask you to try to evaluate if you're a good candidate for chemotherapy. If the answer to this question is also yes, then typically chemotherapy will be recommended to be added to your surgery to improve your outcomes and your results from the surgery. Most commonly, the chemotherapy is going to be given prior to the surgery, kind of called either preoperative or sometimes called neoadjuvant chemotherapy. Those two terms mean essentially the same thing. And so the sequence will be chemotherapy followed by surgery in most patients with muscle invasive bladder cancer. This has been the standard of care. The chemotherapy, a medical oncologist will talk to you about the different options. They're mainly centered around a chemotherapy drug called cisplatin, which has been shown to be the best backbone of your chemotherapy regimen. It typically can last somewhere from 2 to 6 months, and then you go on to have your surgery. Now, the surgery typically will involve removal of the entire bladder, which is called the cystectomy. It also involves removal of other adjacent organs like the prostate, the seminal vesicles, the uterus, the ovaries, and the cervix, and also some of the lymph nodes that are nearby in the pelvis. Now, as Dr. Gore mentioned, cystectomy is an interesting and unique cancer surgery in that it does involve needing to reconstruct some kind of urinary function after the bladder is removed. And there's mainly 3 different types of urinary diversion that can happen after a cystectomy. The first one's called an ileal conduit. It's when you use a section of intestine to attach to the ureters. The ureters are the tubes that are attached to the kidneys that drain fluid and form urine from the kidneys. Normally they attach into the bladder, but now that the bladder is gone, these ureters can be attached to a segment of the ileum, which is part of your small intestines. And then the other end of the small intestines segment is attached to the skin, forming something called a stoma, which there is going to be a session later on talking about stomas. Now, in an ileal conduit, the stoma has no control over the flow of fluid through it. And so there does need to be a bag to allow the collection of the urine, and this bag has to be changed at regular intervals. There can also be something similar to this, but that allows continence. Continence means that you're able to control the flow to some extent, not necessarily control yourself with your muscles, but with continent reservoirs, it's still attached to the skin, but there can be a valve so that you don't need a bag. You instead will catheterize the pouch at regular intervals throughout the day. The last type of urinary diversion is called an orthotopic neobladder. Now, orthotopic means in the right place, and neobladder means a new bladder. So it's a very impressive surgery. It's the formation of a new bladder from segments of bowel the urologist will do, and placed right where the bladder used to be, kind of in the right place. Both ureters are attached to this new bladder, and the urethra is also attached to this new bladder. And it functions as close as we can get to the way the bladder functioned prior to the surgery. So we've talked about, in the 3 different treatments we have for cancer, we've talked about surgery, we've talked about medical oncology with chemotherapy. Is there a role for radiation at all in the treatment of bladder cancer? So typically speaking, the answer was no. The standard approach for many years, and I'd say even today, the standard approach is going to be surgery. And if you can get it, it's going to be chemotherapy prior to that surgery. But we do know in many types of cancer that radiation therapy is a non-invasive alternative that, depending on the type of cancer and depending on your situation, can be just as good as surgery, better than surgery in some cases, worse than surgery in some cases. It's an alternative that we explore in other types of cancer. So in bladder cancer, a combination of trying a non-invasive approach, so omitting the surgery up front and trying to treat the bladder cancer with chemotherapy and radiation therapy, is the foundation of what's called a bladder preservation approach to the treatment of muscle invasive bladder cancer. Some people also will call it other acronyms, just so you're familiar in case you're doing some research online. Some people call it CRT, which just stands for chemotherapy and radiation therapy. It's also called CMT, combined modality therapy, because you're combining different modalities of treatment, or also trimodality therapy, TMT. A lot of different acronyms that all represent the same thing, and an approach to try to preserve the bladder in the treatment of your cancer. All right, so I'm not sure if you can see the small print, but this is a schematic of how this type of treatment is delivered. There's two main types of ways of delivering the radiation. And you can see up here, it splits it into the two main forms of doing it. Before the radiation chemotherapy occur though, you'll see at the very top, an important step in the bladder preservation approach is a maximal TURBT. It's going in with a cystoscopy and trying to get as much, if not all, of the visible tumor that's in the bladder. We'll go over this in a few slides about why this is important, but briefly, we know that results with the bladder preservation approach are better if you can get a maximal TURBT. And so this may even necessitate multiple attempts at going back in and trying to get as much as you can get out. Once you've recovered from that, you would then go on to start chemotherapy and radiation therapy at the same time. Now, as some of you may know, radiation therapy is not a one-shot thing. It's a bit like a part-time job, I tell my patients. You have to go to and from a radiation center every day, Monday through Friday, for many, many weeks, usually about 4 to 7 weeks. But you get the chemotherapy and the radiation together. And this is where the details of the different ways of doing it can kind of split. So one way of delivering it is called a split course treatment. The whole theory behind the split course treatment is that surgery, if it's needed after radiation to the bladder, is more challenging and can make the reconstruction a lot harder. So to try to mitigate some of that, the split course approach doesn't deliver the full dose of radiation that's needed to cure bladder cancer all at once. We go up to an intermediate dose, which also still has a really good rate of response, but also a much safer ability to do surgery afterwards, because it's not a full dose of radiation. So if you can see there in that little box, it says, or it's right here, we usually give up to about 40 to 45 units of radiation. The units of radiation are called the gray. So we give this intermediate dose of radiation, and then we will have the urologist do a cystoscopy to kind of look to see, did the cancer respond to the radiation? If all the cancer is gone after that 40 to 45 units of radiation, we think, okay, this cancer really responded well. Let's keep going and finish the radiation. We'll finish it by giving the extra 20 to 25 gray and getting you up to the dose that we want, which is between 60 to 65 total units of radiation. And all this is with chemotherapy. However, if there's still a sign that the cancer didn't really respond well to the initial 40 units, the thought is it may not respond any better to the remaining 20 units, and it's better to go on to cystectomy, to surgery, if you're a candidate for that approach. The other type of way of doing the radiation is called a continuous course. The theory behind this is, does it make sense to kind of stop halfway through the radiation treatment? Is it fair to assess the response if you haven't given the full course of radiation? And so people who favor this response who favor this course will give the entire 60 to 65 gray with chemotherapy all at once. You give the whole radiation course, and then the urologist will go into cystoscopy to take a look at the response. Again, if there's any cancer left behind that didn't respond to the radiation, they will recommend doing the surgery as a salvage option to remove the bladder. If, however, in either case, all the cancer is gone, then you'll go on to something called surveillance. And surveillance is a really important part of bladder preservation approach. We know that even after a complete response to the radiation right afterwards, it can come back. And in those cases, you want to be able to have the option of salvaging it with surgery. So it will usually involve repeat cystoscopies, repeat blood tests, repeat scans, usually every about 3 to 6 months after you're done with treatment. So what are the results of this bladder preservation approach? It's still relatively early in the life cycle of this new treatment approach, but so far the main studies that have looked at it have said that there's pretty good results in well-selected patients. And so the complete response rate, so at that first cystoscopy, the chances that the cancer is all gone ranges somewhere from about 60 to 90%. In the big studies, like the RTOG studies, it was around 75 to 80% complete response rate. That means though, about 20 to 25% of patients will still have some cancer left behind. And if they're candidates for surgery, will be recommended to undergo immediate salvage surgery. Those that are complete responders who undergo surveillance, studies suggest that even about 10 to 15% of those patients will develop an invasive bladder recurrence that would also be recommended to undergo salvage surgery. But these results in well-selected patients see that 70 to 80% of patients who are alive 5 to 10 years after the treatment still have their native bladder intact, so their bladder was able to be preserved. The natural next question is, okay, it's a good backup option if you're a non-surgical candidate, but what if I'm really healthy? I can have surgery. How does surgery compare to this bladder preservation approach? Now, there are unfortunately no direct comparisons of the two. And the indirect comparisons that we have are very difficult because it's not really an apples to apples comparison. It's kind of apples to oranges. Oftentimes in these studies, the patient populations that had surgery are different than those that had the radiation, maybe because they couldn't have surgery. So we have some indirect comparisons that suggest that in well-selected patients, the results may be just as good as surgery. For not well-selected patients, though, if you can have surgery, that is still considered the gold standard for treatment in muscle-invasive bladder cancer. So I'm starting to run a little bit over, but this is like the last important slide I really want to make sure I go over. And I'm not going to go over every single bullet point in detail, but the whole point of this slide is that, again, like I said before, it's making sure that we select well who is a good candidate for this bladder preservation approach. We know that there are certain characteristics of your cancer that don't respond as well to the radiation treatment. And if you can get surgery, then we'll definitely tell you, surgery is a better option. So part of your evaluation for this approach will be talking to doctors like me and Dr. Wright and Dr. Grivas and determining if you are a good candidate or not for the bladder preservation approach. If during surveillance you do need salvage surgery, I do want to note that because you've had radiation, now you need surgery, the surgery is a lot more difficult. And so the different types of urinary diversion I mentioned before, I think a lot of times the orthotopic neobladder is no longer feasible if you've had radiation. And so you may have to consider some of the other ones. Tissue healing is also a little bit more complicated after a body's been radiated. And so there can be increased wound issues and healing issues if you have to have surgery after radiation. I don't have time to go over everything about changes in radiation therapy like I'd hoped, but suffice it to say that things are a lot different in the way that we deliver radiation therapy today than even 5-10 years ago. Radiation therapy is a field that's really heavily reliant on technology, robots and machinery and programs. And so as technology advances at a fast pace, so has our ability to deliver radiation effectively and safely. And the studies that have looked at bladder preservation approach have shown a huge difference in how effective bladder preservation treatment is in the modern era compared to even 10 years ago. This is my last slide. So if you do come to SCCA, you have muscle-invasive bladder cancer, and the doctors recommend that you are a candidate for bladder preservation. We do have a clinical trial that we're running here as well. It's called the SWOG 1806 trial. It's a great trial that's Dr. Grivas is part of heading up, and it's a comparison of chemoradiation plus or minus immunotherapy for your muscle-invasive bladder cancer. Sorry for going a little over time, but thank you, and now I'll pass it over to Dr. Montgomery.
Thank you, Jonathan. I appreciate that. We're running a little bit over time, but I suggest folks to post questions in the chat room. Already I see great responses by many colleagues. One question was about the role of adjuvant chemotherapy, and Dr. Montgomery already answered this. And this applies to patients who never received neoadjuvant, so never received what Dr. Jonathan said, preoperative before surgery chemotherapy, and the answer was given by Dr. Montgomery. Bruce, thank you so much for joining, and we'll pass it off to you.
Thanks again. Thanks to Dr. Grivas and Dr. Wright for inviting me to talk. It's very good to see everybody on the Zoom since we're not in person, but again, thank you. I'm going to make this pretty brief. I also wanted to actually give Dr. Chen, that was a tour de force, so thank you for that. Pretty remarkable. So my role today is to talk about a situation in which we're really talking about folks dealing with cancers which are more advanced, meaning that they can't be curatively treated with radiation or surgery. And so the focus is really on systemic therapy. Now, that's a very difficult situation to be in. And that happens either because the cancer is not detected early enough for it to be treated with surgery or radiation, or if in some folks, despite the radiation or surgery, the cancer does come back. And in that situation, we focus on treating the entire body in order to reach as much cancer as we possibly can. So I would say one of the things that is the most heartening thing to me is how much progress has been made in this area over the last 5 to 10 years. I've been in this business long enough, as you can all see from the lack of hair, that we used chemotherapy forever and nothing really changed. And then very recently, all of these other options, which I'm going to talk about in just a moment, have become available to people. And all of them, I know there are many people on the call who want the nitty-gritty details. I don't think we're going to be able to do that in this setting. I'm going to describe what these therapies are. All of them have better outcomes attached to them. Some of them have a cure rate, which is what we're all after at the end of the day, is getting rid of this for everybody who has to deal with advanced bladder cancer. But we are making progress, and research has made unbelievable steps in the right direction over the last several years. So the two situations we're talking about here are folks who have had cancer that started in the bladder and then spread to other areas. That's called metastasis. That can happen in any malignancy of any kind. In bladder cancer, it's common to go to a number of different areas. I'm not going to really talk about that, but it means spread, but it is the same cancer that started in the bladder when it gets to someplace else. So we really are talking about treating everything everywhere. The other scenario which makes it difficult to treat people with surgery or radiation is if the cancer has gotten through the bladder wall into an organ nearby, such as a muscle, or if there are lymph nodes that are involved which cannot be adequately treated with chemotherapy prior to surgery. And in that situation, we really are talking about disease which, again, cannot be completely eradicated. And so we focus on treatment. Treatment in essentially every situation is associated with better outcomes. So response rates, survival, and everything else. So the focus here is going to always be, if you see a medical oncologist like us, that we're going to want to be using treatment in this situation. So there's a lot of details in this slide. I'm not really going to talk about them. I would say we all know that your own immune system is probably the best cancer fighting agent we can come up with. If people develop cancer, the immune system obviously wasn't enough to take care of it. But immunotherapy, which is usually intravenous administration of what are called monoclonal antibodies to sort of ramp up your immune system, can be extremely effective. So many areas in oncology are focused in this area. Bladder cancer is among them, and it has really revolutionized many of the ways that we go about treating the disease. So a lot of drugs, I'm just going to touch on them briefly later, but the idea here is we take the brakes off, and if we can activate your immune system adequately, it can be remarkably effective. Another area that has been a big step forward has been that we realized that a very specific target, something called the fibroblast, easy for me to say, fibroblast growth factor receptor, was something that was driving bladder cancer in a significant number of people. If that gene and protein is altered in a way that sort of hyperactivates it, so that it's driving all these aspects of cancer progression, then turning off the activity of that enzyme, because it is an enzyme, it phosphorylates different proteins, with a drug called erdafitinib can be very, very effective. So this again is a new area within the last 5 years. And finally, just to talk about something that I think is going to be one of the big steps forward in a number of different therapeutic options in this treatment of bladder cancer. There's one drug that's been FDA approved called enfortumab. So the idea here is we have drugs that can be extremely effective against cancer, all right? The problem with it is that if the rest of your body is exposed to these very toxic chemicals, then it's very hard for people to tolerate them. So the way that we've tried to address this is by tagging the very effective chemotherapy onto something which goes straight to the cancer and doesn't expose the rest of the body. So this is what's called an antibody drug conjugate. So this very nice schematic is supposed to show us that this drug, that is the combination of the antibody and the drug and the chemotherapy, recognizes something called Nectin-4 on the bladder cancer cell, gets incorporated, and then only releases the drug when it actually gets into the cancer cell, where it can have the greatest effect. So this is another area where we've made real steps in the right direction, and this drug, I think, is being incorporated and being investigated in many different stages of cancer, including localized bladder cancer, such as what Dr. Chen was talking about a moment ago. So I'm going to, again, in the interest of time, I'm going to abbreviate this a little bit, but you know, the situation is that there is the best of all possible circumstances, and then sometimes not. So chemotherapy, although it's the most effective treatment that we have still in this situation, most likely to cause a response, best outcomes associated with it, you have to be in a situation where you can tolerate it. So it is a weighing out of the risk-benefit ratio for people. If folks have inadequate kidney function to tolerate cisplatin, or they simply are not in a great place, it's hard to use cisplatin-based chemotherapy, but our standard of care is some cisplatin chemotherapy for 4 to 6 cycles, and then immediately starting an immunotherapy called avelumab. Now, this study came out about a year ago. Dr. Grivas was one of the principal investigators driving this, and the best outcomes in advanced bladder cancer are associated with using this combination of chemo followed by immunotherapy immediately. If people haven't gotten immunotherapy, that becomes the next thing to do after chemotherapy. And then using either the FGFR inhibitor that I talked about, erdafitinib, or enfortumab, and they don't have to be in any specific sequence, but people have to have a specific alteration in their cancer for the erdafitinib to be relevant. So that is not the right therapy for every patient. Sometimes we use other chemotherapy down the road, although that's much less common these days. And I would say all of these interventions have come to the clinic because of research. Everyone that you're going to hear speak today is involved in that research. And I can't emphasize enough how important it is to participate if it's the right thing for you. I know Dr. Grivas is going to give another talk later in this session, but I just wanted to reemphasize how the only way we make progress is with research. So for some people, cisplatin isn't the right thing, and we use carboplatin. Again, the sequence is essentially exactly the same. It's just that we're using carboplatin instead of cisplatin. And then for some people, you know, they're just in such a place because the disease is affecting them so badly, or because of other medical issues, that chemotherapy simply is not a good option. And in that situation, most of the time what we're using is immunotherapy. These are all the different drugs that are available to do that, and then the subsequent other treatment options. So I think the one thing that I just wanted to emphasize is how much progress has been made recently in the systemic therapy of bladder cancer. There's more money, more clinical trials, more interest in this area, and I am very optimistic that we will continue to make a very rapid progress in this space. So I think that's everything that I had. Yep.
Thank you so much, Bruce. A wonderful presentation by both you and Dr. Chen. Really, I want to emphasize all the points you made, especially the point about research, and all of us, as you mentioned, are involved in this, trying to move forward and help the patients. In the interest of time, we'll move on to the next session. I want to point out there is a great question and answer session going on in Zoom in the chat room. So please post your questions, and all of us, we're trying to answer all of them one by one. With that note, again, thanks so much, Jonathan and Bruce, for a wonderful presentation. Jonathan, this is back to you.
Great, thank you, Petros. So this next session, we're going to talk about some of the different aspects that are just critical for us to manage the entire patient and the entire individual. And so to start with, we're going to talk about a question that many people ask us, what has to do with nutrition. We're going to continue to talk about the need for more and more research in some of these areas. We're very lucky to have Dr. Marian Neuhouser present today. She is the program head over at the Fred Hutch Cancer Research Center for Cancer Prevention, for the Cancer Prevention Program. She also holds positions both in the Department of Epidemiology and Nutritional Sciences at the University of Washington. She is currently leading, the American Cancer Society is redoing across the board their guideline recommendations for nutrition and cancer. And Dr. Neuhouser is on this, and she is leading the genitourinary section, which includes bladder, prostate, kidney, etc. So I'd like to turn it over to her, and she has been an outstanding mentor to me as well in developing my research career too. So with that, I'll turn it over to Marian. Thank you.
Thank you, Jonathan. Appreciate that introduction. So good morning, everyone. Thank you for spending part of your Saturday morning with us. And as Dr. Wright mentioned, I'll be touching a little bit on nutrition this morning. Here are my disclosures. They're all research funding disclosures, as well as I'm an associate editor at the Journal of Nutrition. So when we think about nutrition and physical activity recommendations after a cancer diagnosis and treatment, we always want to make sure that everything is evidence-based. In the first set of talks, you heard a lot about how research drives various treatments, whether it's chemotherapy, other agents, radiation, surgery, and so forth. And we do the same with nutrition. We really want research to inform what we tell patients. There are a couple of expert groups that I want to draw your attention to, and these expert groups review and evaluate the totality of the evidence. So when we make recommendations to patients, we don't rely on just one study here and there. We rely on the totality of the evidence. And the first one, as Dr. Wright mentioned, is the guidelines put out by the American Cancer Society. It was last updated in 2012. I was also on this committee. And as Dr. Wright mentioned, the 2021 report is underway. All of the various working groups, including the GU one that I am leading, we are currently reviewing all of the literature. We expect that the publication will be out in the fall. So this is really a treasure trove of the accumulated evidence that will guide recommendations for patients. Another group that I can highly recommend is the American Institute for Cancer Research. And they put out these continuous update projects, usually on an annual or sometimes every other year basis. And again, there are expert groups of researchers in nutrition, physical activity, oncology, epidemiology, biostatistics that gather together to review the published research, and they happen to have done one in bladder cancer recently. That one was published in 2015. So let's think a little bit about cancer statistics. Every year there's a report that comes out that documents the estimated number of new cases and number of deaths from various cancers. And you can see here that for men, urinary bladder, even though we still consider it a rare disease, it's among the top 10 of the cancers. And same for kidney and renal pelvis cancers, remains in the top 10 of all cancers for men. And for women, kidney is among the top 10, but not bladder. But despite the fact that bladder and urinary tract cancers are common, research on nutrition after a diagnosis is not as extensive as it is for other cancers. We have a lot of data, especially on breast, colon and rectum, in both men and women, and growing in prostate, including work that Dr. Wright and I are doing together. But we really do need more research, especially in bladder cancer, to drive the evidence base and to drive how we guide patients. So diet is complex. That's one of the reasons I really have enjoyed being in this field for the past 30 plus years. We have 3 macronutrients. Those are components that we get calories from: protein, carbohydrate, fat. We also get calories from alcohol, but we don't really consider it a nutrient because it doesn't really provide us anything healthful except for calories. We also have micronutrients. Those are vitamins and minerals, fiber, phytochemicals, which are not essential nutrients, but they're important for health, and disease prevention. Those include things like flavonoids, carotenoids, polyphenols, isoflavones. Food also contains contaminants such as pesticides, herbicides, nitrosamines, and pathogens. So food is really complex. And what we do as researchers is we take what people eat and then we divide it down into all of these various components. We figure out what is in these foods, how it's metabolized in the body, how it's affecting certain pathways. You heard in Dr. Montgomery's presentation a little bit of talk about enzymes. Well, vitamins help the enzymes work. There are things called cofactors that latch on to the enzyme that make the enzyme work. You've heard a lot about muscle walls and other things. Well, what's in those muscle walls? Protein, carbohydrate, fat plays an important role in the immune system, both improving immunity as well as decreasing immunity. So all of these things that are in foods go into all of these reactions down at the cellular level. And that's part of our job as researchers. And we try to do this in rigorously controlled randomized trials, just like the treatment trials are based on randomized trials. We try to do this with nutrition as well. As researchers, we also recognize that nutrition is more than just nutrients. You don't want to hear us talking about, nutrients. Nutrition is also taste, enjoyment, it's family and friends, health of the planet, it's culture, celebrations and holidays. And we also recognize that it's stress and emotion. Some people eat more or eat differently when they're under stress, including when they've just received a cancer diagnosis, and the family may react that way too. And some people eat more. Everyone reacts to stress differently, but we need to try to understand how that affects people's appetite and their eating patterns. So we recognize that nutrition is more than just this collection of nutrients, phytochemicals, and other things that go down to the cellular level. Our current research indicates that dietary patterns and diet quality are really important. We recognize that no single food has all of the nutrients needed for health, and we recognize that people eat foods and not nutrients. There's no single, what I might call a magic food or a magic nutrient. Dietary patterns are the totality of foods and beverages in the diet and the frequency with which they are consumed. It's very important to remember that the whole is more than the sum of its parts. It's what's consumed day in and day out, week in and week out, year in and year out, because much of what we're dealing with, especially cancer, is a chronic condition. So what someone eats on any one day is not as important as the pattern over a matter of weeks and months and years. So what are healthy dietary patterns? There's a comment from Mr. Cohen at the beginning about a plant-based diet. And this is a very nice illustration of that. It's not all plants in these two examples, but you can see a lot of plants, lots of colors in these foods. So variety, diversity, lots of color. The more color you can get on your plate, the better. Think about eating the rainbow. And maybe less often something like this, but it doesn't mean you can't have that. Occasional treats are fine. Holidays are great. Again, what you eat on any one day is not as important as what you eat over the course of a number of weeks and months and years. Our job as researchers is to try to understand how what you put on your plate is broken down into all those components I mentioned: fat, carbohydrate, protein, vitamins, minerals, phytochemicals, and how those are broken down into these minutiae that feed into various biochemical reactions. And your responsibility as patients and patient families is to think about having meals like this. I would suggest that you avoid what I call popular fad and restrictive diets. You may have seen a lot of books like this, seen things on the internet that promise a lot. Most of these diets are very restrictive. For example, the paleo and the keto diet have very few whole grains, and they're very high in fat. Well, our research suggests that that's not a healthful diet for the long term. We need grains in our diet, in part because that helps the bacteria in our gut to be healthy, as well as for a number of other important biochemical reactions. Many of these popular diets have a lot of promises that are not based on good science. And again, what we tell patients, we want it to be based on randomized controlled trials that are rigorously done. We don't want it based on some idea that someone came up with that's not based on good science. In addition, many of these highly restrictive diets can produce nutrient shortfalls because they're very narrow. They tell people to only eat a certain number of things. And as with anything, if it sounds too good to be true, then please be cautious. So I'd like to end with some recommendations that are issued by the American Institute for Cancer Research. These are general dietary and physical activity guidelines for all cancer patients. They're not specific to bladder cancer patients, but they include trying to maintain a healthy weight, be physically active, even start small, take a 15-minute walk in the morning, see if you can work it up. Eat a diet rich in whole grains, vegetables, fruits, beans. Again, make 2/3 or more of your plate with produce. Limit consumption of fast foods and those that are high in fat, sugars, and starches. Limit consumption of red and processed meat. Doesn't mean you can never have it. Just try to limit it and make it a once in a while treat. Limit consumption of sugar sweetened drinks. That would be things like soda pop and even some alcoholic drinks, cocktails that have sugar added to them, and many of the beverages that you can get at a coffee bar that have sweet syrups added to them. Limit alcohol. And it's important to remember not to use dietary supplements either for cancer prevention or for survivorship. If your provider suggests that you take a multivitamin for whatever reason, by all means do that. But there's no reason to take a large number of supplements that are available over the counter on the internet and so on. So thank you. Thank you for being here today, and I look forward to your questions.
Neuhouser, thanks for a great review and also great advice for not just our cancer patients, but for those of us, all of us on the audience today. So that was wonderful. So I think we'll continue on. Please posting questions in the chat that we can answer as needed. I'm going to move on to our next speaker, Dr. Sarah Psutka, who is one of my partners here at the University of Washington in the Department of Urology. She is a urologic oncologist. She joined a couple of years ago here. comes from Harvard Medical School, Mass General for residency, Mayo Clinic for urologic oncology fellowship. Has been a tremendous addition. And what's beyond being a fantastic clinician and surgeon, she also has brought some exciting research avenues to our program as well, looking at resiliency for patients and figuring out who's safe for surgery moving forward with cystectomy. Also the role of body composition and how that changes through treatments, both chemotherapy and surgery. And finally, some new work looking at acupuncture for patients too. So I'm very excited to introduce her today to speak a little bit about survivorship.
Thank you so much, Jonathan. Thank you to Petros and Jonathan for the wonderful invitation. I love this meeting. I got to participate in it the first time a couple of years ago, and I wish we could all be together, but I am thrilled to be spending Saturday morning with you all. I am going to talk about my favorite topic to talk about with bladder cancer, which is survivorship. So I'm going to share my screen, and we're going to get into this. A huge thanks to the SCCA and Beacon and the Howard J. Cohen Bladder Cancer Foundation for supporting this incredible opportunity to speak with you. And these are my disclosures. I have some research funding from Beacon who have supported my work on resilience, and I'm so grateful to them. We are excited to we're getting ready to present those results coming this summer, and also the Cancer Consortium here at the Fred Hutch who are supporting our acupuncture trial. Okay, so who's a survivor? Definition of survivorship is very broad. It encompasses any individual, and basically any individual is considered a cancer survivor from the time they are diagnosed, during and immediately after treatment, and throughout the balance of his or her life. But it's important that we also consider the other people who basically touch survivors' lives. So family members, friends, and caregivers also affected by the cancer are kind of encompassed in this definition. And when we talk about cancer survivorship, we're talking about really taking care of patients from that moment that they receive that diagnosis through the rest of their life. And I want to talk about principles of survivorship care. So this is how we really care for the whole person as they are going through this journey and understanding this new way of living with the diagnosis of cancer and living well. And so there's 5 key components we're going to talk about today. And specifically, I'm going to spend the next 10 minutes talking about how these components interact with you as someone who's dealing with bladder cancer. So we're going to talk about prevention, and that's both of new or recurrent bladder cancer, as well as prevention of late treatment effects. So the toxicities or the side effects or the complications of therapy, how do we prevent those from interfering with your quality of life? We're going to talk about surveillance for bladder cancer and recurrence or spread, but also screening for new cancers. We're going to talk about
Dr. Psutka, I just want to interrupt you for a moment. I don't think you're sharing your screen.
Oh, is it not working? I'm sorry, I apologize.
No problem.
Share it. Are you not seeing? Let me try something else. I'm using, I apologize for that, everybody. Is it working now?
Yes, it is.
Okay.
Thank you.
My apologies. I think that this far into the pandemic, we would all understand how to use Zoom.
No problem.
Okay. Can you see my screen, my slides now?
Absolutely.
Yes.
Okay, wonderful. Let's get back into it. So we talked about survivorship, and now can you still see my slides?
Yes.
Okay, good. Sorry. I think my computer thinks it's smarter than I am. It's got multiple pictures going on here. So we were going through the components of the principles of survivorship care. So we talked about prevention, we talked about surveillance, we talked about the assessment of late effects, and we're going to get into how those side effects affect both your body but also your psyche, your psychosocial existence, and how we can actually help manage these side effects. And then I want to talk a lot about coordination of care and how your entire team comes together to help you live well as someone who is a survivor of cancer, and thinking about how we plan for ongoing care. So these are the 6 components, and we're going to take them one at a time, how they interact with you as a bladder cancer survivor. So I was asked to speak about survivorship across the spectrum of bladder cancer. So first, non-muscle invasive disease. You heard a wonderful presentation this morning by Dr. Gore about how we think about non-muscle invasive disease and all of the different ways that we treat that entity, that type of bladder cancer, which affects 70% of all patients with bladder cancer. The therapies that people with non-muscle invasive bladder cancer receive, those medications that go in the bladder, whether it's BCG, whether it's chemotherapy, or some of these more novel agents, or whether it's pembrolizumab or any of the immunol agents that we're moving into that arena, they have some significant side effects that can extend past the time when you're getting those 6 weeks of treatment, or the 3 weeks of maintenance courses. You can have blood in the urine. There can be pain with urination. You can feel fatigued and run down, and you may have pain in your low back or pelvis. The important thing to know as you're experiencing any of these side effects is to let your physician know about it, because there are things that we can do to help mitigate some of these side effects, whether it's helping you manage your bladder symptoms, making sure that you're emptying your bladder appropriately. If there's blood in the urine, we want to know about it for sure, as Howard brought up in the chat room. We want to be able to talk to you about that so that we can potentially look and see, why is this happening? Is it an infection? Or is it cancer that's come back? Or is it, for example, with someone who's had radiation, is it a complication of the radiation? So all important things for us to know about so that we can help you. Any of you who have had conversations with us about radical cystectomy have gone through the long conversation where we talk about the side effects of cystectomy in the short term, but we also talk a lot about how radical cystectomy can affect your body in the long term. So this is a complex operation. As Dr. Chen mentioned, we go through, it's not only the removal of the bladder and the surrounding organs and the lymph nodes in the pelvis, but then it's a big reconstruction where we basically figure out how to create a new way, a new reservoir for your urine, a new way for urine to exit your body. In the long term, there are cosmetic considerations as people are learning how to live well with a stoma or a neobladder, how to do the things that they love to do with this new plumbing that we've created. There's risks of hernia, both at the incision site and around the stomas. There's new ways we have to get ready to figure out how to get rid of the urine. And certainly learning how, we're going to have a great presentation coming up on stoma health and stoma maintenance, but also how to manage a neobladder for folks who have to learn how to get rid of urine with this new bladder that we've created. In the long term, when we use intestine to store your urine, there's metabolic concerns that can arise. And you have a picture of the bone here because that actually can affect things like bone health. Your gut was born to absorb. And now we have a piece of gut sitting next to a waste product or urine. And unfortunately, that bit of gut doesn't know that it has a new job. So it's going to keep absorbing all the things that your body's trying to get rid of, which means that we may have to put you on certain vitamins, medical supplements. I put all my patients, and all of us do here, on calcium and vitamin D to help protect your bone health. Some of the fat-soluble vitamins that Dr. Neuhouser was just talking about that are really important for the functioning of our nerves are absorbed through the part of the bowel that we use for this reconstruction. So you might have to go on supplementation. So lots of long-term side effects and it's going to be critical that we're going to be talking to you about these side effects and looking for these and trying to figure out how we can handle them as we're seeing you going forward after your treatment. There's a big impact of this disease on sexual health. And this is something that we start talking about early on because we know that all the therapies we have, unfortunately, impact the ability of men and women to have in some ways satisfying sexual health, and there are things that we can do to fix that, and there are things that we can do, there are strategies we have to try to avoid the implications for sexual health. But this is a big thing to talk about with your physician as you are planning the therapy for you and selecting the right treatment for you. And then after you've gone through therapy, we want to be checking in about your sexual health so that we can understand how we can help preserve and optimize your overall quality of life and the quality of your sexual health. And this is important for how you think about your body, you think about your sex drive, you think about your psychological distress. And so certainly this is a key component of survivorship and a big part of how we help take care of survivors. Dr. Wright mentioned a little bit about my interest in body composition, and one of the things that I'm passionate about is muscle mass. And the fact that cancer takes away muscle mass, and that's a concept called sarcopenia, or low muscle. We know that our treatments result in decreased muscle mass, and actually we have some really exciting research that we just are getting ready to present that show in detail how chemotherapy impacts muscle mass, and also how bladder cancer itself and surgery impacts muscle mass. And when we lose muscle, and this can be part of a cycle that has to do with your nutrition intake, but it's also just something that's related to the cancer itself, it can impact your physical performance and or lack thereof, and this concept of frailty or decreasing physical performance, it can make it harder for you to get the medicines you need. It can decrease survival and therefore life expectancy, but it also affects things like your symptoms, your quality of life, and when people look at themselves in the mirror, how they kind of feel about themselves. So this is something we are working actively at, trying to figure out how we can help preserve muscle mass, because we know it's good for cancer care and cancer survival, but it's really important for how you live your life and your survival and your overall quality of life in general, outside of just being a cancer survivor. Psychosocial long-term and late effects, we've touched on some of this a little bit, but the other thing is all of our therapies really affect how your mind works. And this is important. And not only do our therapies impact how your mind works and how you think about yourself and how you live your life, but the diagnosis of cancer in and of itself is associated with a tremendous amount of anxiety, a risk of depression, a risk of mental health concerns, and it can impact self-confidence. We're going to talk in a minute about the amount of follow-up that we have for bladder cancer. And I know that patients, we've had this concurrently with this meeting. There's an amazing bladder cancer meeting happening right now that the AUA, the American Urologic Association, is sponsoring, where we were talking about patients gave a panel where one of the survivors said, "I live cystoscopy to cystoscopy." And that really resonates with me, because I know that my patients every 3 months when they're coming in, all they're thinking about is, oh my gosh, are we going to find another cancer? And sort of people kind of live their life between cystoscopies, but then there's always these bookends. And whether it's cancer follow-ups and getting CT scans or coming in for cystos, it really can affect your quality of life. So I want to, as you are going through your survivorship care, your physicians will be checking in with you about your mental health and how you're kind of feeling. But it's important for you also to feel very confident coming to us and saying, hey, I'm really struggling with this, because we have resources here at the SCCA and through the University of Washington with our amazing colleagues in mental health and in the survivorship clinics that we have at the Cancer Center to help you, again, handle these concerns and live well with the diagnosis of cancer. We're talking a little bit here about surveillance. What I was just referencing is I often tell my patients, unfortunately, for better or worse, we're going to be lifelong friends, because once you have this diagnosis, to some degree, it becomes a chronic disease. Even when you get through therapy, we are following patients up with non-muscle invasive disease for those cystos every 3 months initially, and then it gets to stretch out as we get further and further from a recurrence. Muscle invasive disease, we start seeing patients after cystectomy every 3 months for their cancer surveillance, and that does stretch out over time. But we also are seeing people to handle their side effects. So it's a lot of visits. One of my favorite things is seeing my patients come back, but this is a big burden to some degree for patients to carry, and it's a lot of time. It's a lot of travel. Telehealth has helped us a little bit because we can do some of these visits, but cystos, unfortunately, we don't have a way to do those over the Zoom yet, although I'm sure maybe someday we'll figure that out. But it's a big commitment to be a cancer survivor. And it becomes a big part of one's life. And so I think this has a lot of implications, both for cost and financial toxicity. And this is something that we are, I think, paying more attention to now. And it's a really important part of your cancer care and a patient's ability to continue working. So all of these things are things that we want to talk to you about as you come to see us for your survivor checks. Screening for second primary cancer is important. Just because you've had bladder cancer, unfortunately, doesn't mean you can't get another cancer. And so all this means is we want to make sure we're doing all of the other things to keep you healthy. And that includes following screening guidelines for things like colon cancer. But if other symptoms pop up, things like blood in the urine or rectal bleeding, especially in folks who have had a history of radiation, we want to make sure that we're checking you for these potential second malignancies. And so this is a big part of survivorship care. And then health promotion. So I think any of you who are my patients know that we talk a lot about this, and I know so do all of the other providers here, but we're big proponents of keeping you healthy and allowing you to live well while you're going through treatment and then survivorship. Healthy lifestyle habits, as Dr. Neuhouser just talked about, are associated with health and quality of life. And we take a three-pronged approach here. We want to work on giving you the best possible diet, helping you be physically active and manage your weight. And we know that all bladder cancer, we definitely encourage all bladder cancer survivors to achieve and maintain a healthy lifestyle, because we know this is associated with quality of life. And this is how you can take back control. I hear a lot from my patients about how the moment they received the diagnosis of cancer, they felt like control was taken away from them. These are things that you can do to sort of put yourself back in the driver's seat, take control of your life, and help you live well. And this includes everything from quitting smoking and minimizing alcohol use to optimizing your medical problems, exercising, improving your nutrition, staying hydrated, and taking care of yourself and sleeping. You need to rest to heal. So this is an important part of your overall health and wellness. And then the last part is care coordination, and this is critical for cancer survivorship. When you're a survivor, you've got a big team, and your bladder cancer team is not only your surgeon or your medical oncologist, it's also your primary care physician. Especially as you get further out from actually getting through the active treatment, the primary care doctor starts to take over more and more of your care. Your stoma team, your nutritionist, and maybe other members of our physical and medicine rehab team and things like that. So the principles of care coordination, I think the biggest thing here is communication. So we always want to know at each stage of you going through your disease process, whether you're going through a diagnosis of non-muscle invasive disease and going through initial treatment, or you're unfortunately handling metastatic disease and you're dealing with medical oncologists and potentially other members of our team who help you during those advanced stages. We want to know who's the boss at that moment, because that's going to be your main point person. And that's going to be the person that you're going to go to with the first concerns that you have. What are the responsibilities of every member of your team? We want to make sure that when you transition from team member to team member, so let's say you get through radical cystectomy, you get through that first 5 years, you're doing great, you're disease-free, and you're going to start to spend more time visiting with your primary care doctor than your urologist. We want to make sure that transfer of care is well coordinated, so that your urologist talks to your primary care doctor and says, hey, these are some things that I want you to be checking in on for this patient. And so things that a strategy or something that can be very helpful in managing that transition is the treatment summary and survivorship plan. And this is just a written document that sort of transitions care in a very clear way. And then, of course, we also want to use our community-based and peer support services, things like Beacon, the peer services that are out there to help maintain your quality of life as survivors. And so this is a sort of a summary of the things that survivorship care plans detail: checking in about your mental well-being, your physical activity and exercise, your sexual health, your urinary and bowel function, and your financial well-being. And we want to hear from you at every step of the way what we can do to make sure that these are all optimized. And that's the crux of survivorship. So I want to thank you for the opportunity to speak with you today. I think if we just to sort of summarize what we talked about, bladder survivorship it encompasses the entire lifespan of dealing with the disease bladder cancer, and a survivor is a patient at any stage in that journey, as well as all the people that are close to them that are supporting them as they're going through this diagnosis. Key components are information sharing, making sure we're checking in about physical and psychosocial side effects of the therapies, and then optimizing everything else in life, other comorbidities, nutrition and lifestyle factors. We want to partner with our patients and their families, and then we want to make sure that the care team is talking well and sort of everyone knows their roles and is really supporting patients. I want to thank you all for the opportunity to speak with you today. I'm going to stop sharing my screen and look forward to the opportunity to answer any of your questions.
Thanks for a fantastic talk, really showing the comprehensive aspect that you strive for, and we all strive for in care of our patients. So thank you very much. I think we'll keep moving in the interest of time. Keep posting the questions on the chat. It's working very well. I want to introduce our next speaker, Colleen Carvenan, who has been a partner of ours and mine for a number of years now. She is a wound ostomy clinical nurse specialist. When she started here, she was the only person, and now she leads 5 people doing this role for us at the hospital here. She's also perfect to speak because she's an instructor in the biobehavioral nursing and health systems at the UW Nursing School. So Colleen, thank you for participating, and thanks for all your help with our patients.
Yeah, happy to be here. So I want to talk about living well with an ostomy, and I typically meet patients for the very first time after our multidisciplinary bladder clinic. And part of my job is to find out what have they heard so far? What are they understanding so far? And to address what their immediate concerns are. So my objectives for this talk, and I think to describe an ostomy, to discuss pouching systems, and discuss life with a urostomy. And really, we want the patient to take ownership. The ostomy can control you. It can limit you to the things that you do if you don't decide, I'm going to accept this, and that's not immediate, it's a process, but not let it run you. So I'm gonna show you what an ostomy looks like in the next slide. So an ostomy or stoma, we use those terms interchangeably. So a stoma is essentially an opening or a mouth. So your ostomy will be a permanent opening on your abdominal wall, typically on the right side. It's made during a surgical procedure. So the next slide. And so creating an ileal conduit, when I first see the patients, I ask them, what do they understand about it? Do they understand what the surgeon's going to go in there and actually do? And as part of the small intestine, you think, okay, they're going to take part of my small intestine. What will my bowel function be like after that? You're not going to notice it because you're still going to have a continuous loop of bowel. And so I'm, try to help them understand that the ends that they cut to take out that small segment to create the ileal conduit, the passageway, they're going to reconnect your bowel so you still have continuity. And then one end is so closed, the ureters are attached to that piece of intestine, and the other end is brought to the surface of your skin. So you're looking at inside out intestine. So next slide. And big question is, where will the ostomy be on my body? And I'm showing you two pictures of very different body types. And you don't have to have somebody's ideal of a perfect body for an ostomy. We work with you and your body to figure out what's the best spot for your ostomy. And it's super important the ostomy nurse sees you for this, because if you are lying flat on an operating table, most people's bellies look fantastic when you're lying flat. You sit up, stand up, bend forward, lean, wiggle around. It's not quite so perfect. So we want to find the best spot for you to have the most success with managing your ostomy. Next slide. So what can I expect? What can you expect if you have a urostomy? So you want your urine to be clear yellow urine, but it will always have a little bit of mucus. Why is that? Because we use a piece of the intestine to create the passageway, the ileal conduit, and nobody told that piece of intestine that their job has changed, and the cells lining that piece of intestine make mucus. You want that mucus to be really thin strands, and if you don't drink enough fluids, then the mucus can get really thick and can even kind of plug things up. So you want that's one indicator, light yellow urine, and that really thin strands of mucus tells you you're drinking enough fluids. What's enough fluids? To do exactly that, keep your urine light yellow and to keep that mucus thin. And a big worry people have is, are people going to know? Are they going to smell this? The only time you're going to have odor is when you're emptying your pouch. Or the other time is if you have a leak, then you would have odor. But when everything is working fine, there's no odor at all. Next slide. So these are some pictures of real stomas of patients that I've taken care of. The one on the left is very early on post-op, still in the hospital. The stents are in place. Those stents will be there for a little while, a week or so, sometimes less. And they once they're out, it's really easier to manage the ostomy once they are out. And the picture on the right shows you an ostomy. It's a different one, not the same person. And there's no stents, much easier to manage that way. But on both of these are pretty early on, pretty close to when surgery happened, because the stoma is really smooth and it's swollen. Over time, roughly 6 to 8 weeks, that swelling of the stoma is going to go down. It'll be very wrinkly. So if you ever look at pictures at your colonoscopy and how wrinkled, you might say, how many folds and things your bowel has, you're going to have more wrinkly looking stoma, and that's what you can expect. Next slide. So what's the bag or the pouch that you need to wear? And you're going to wear it constantly. So the pouch, there's many manufacturers. We start with a specific one, our favorite, but that doesn't mean it's what you have to stick with. We work with what adhesive works best with your body, what pouching system is most comfortable for you to wear, because the fabrics and things that they're made out of work a little differently. The adhesives are a little bit different. There's some that you have to cut the opening to fit around your stoma, and we show you how to do that in the hospital. There are some that you just stretch the adhesive part on the wafer to fit around your stoma. We figure out what can you do if you have limitations with dexterity, any of that. We work with you to find the best system. And so you're going to empty your pouch when it's a third to a half full. And this is something that you are the best person, as the person with the ostomy, to manage. You know when you start to feel the weight and the bulk of it, and when you need to empty it, and emptying it when it's a third to half full, it helps keep the adhesive intact for longer. You don't want to get really full and heavy. Now, these pouches have anti-reflux features, so the urine is not pooling around your stoma. If it pooled around your stoma, then you'd have a better chance of undermining the wafer or the adhesive that sticks to your skin. And a beautiful thing about the ostomy, your ostomy too, is you're going to be getting up less at night. So you can connect this to an overnight bag, because you can make a lot of urine at night. And if you have a two-piece system, we show you how you can turn your pouch to the side. So you can lay on one side, your back, or roll over to the other side and still have a straight shot of drainage to your overnight bag. So you're not getting up multiple times a night to empty your bladder. Next slide. So skin around your stoma, and this is one of the most important and common complications that we get. We want the skin around your stoma to be healthy and free of irritation. The beautiful skin you have on your belly right now, before surgery, you want it to be that beautiful forever. And so when you change your pouching system, you're going to clean that skin with water and a washcloth. You want to avoid soaps and, any soaps really. And you want to not put creams or lotions, because all of that will impact with how your pouching system fits. You can shower with your pouching system on or off. You're not going to hurt your ostomy at all when you're showering. And when we see patients over time, and truly we want to see you over time, is we want to know, how does your skin look? Because you might think, oh, this is normal. It's normal to have a little bit of redness. It's normal to have a little bit of skin breakdown. It's not, but we can help you find another system that's going to work better to keep your skin looking great. So diet and fluids, Dr. Psutka talked a lot about diet, and having a urostomy in and of itself has very little effect on diet. It doesn't limit what you can or can't eat, but there's important things to know. Like if you eat food like beets, for example, it will color your urine, and to just be aware of, why is my urine red? Do I have a problem, or is it something that I ate? If you eat asparagus or have seafood right now, for people without ostomies, their urine changes in odor. Yours will change in odor too, but remember, it'll be only when you empty it. It's not like anybody can tell when you're running around that you are having odor. And drink plenty of fluids every day. How much? We can't say that, oh, you need 2 liters or 2.5 liters or 1.5. It really depends on how do you keep your urine a light yellow, and that for how much fluids you need. Next slide. So learning about an ostomy, my goals in an initial ostomy visit are for you to understand what an ostomy is and what it looks like. I want to know what immediate questions you have. You heard a whole bunch of things from your urologist, a medical oncologist, a radiation oncologist. I want to know, what do you understand? What questions? What are you worrying about right now? And my goal too is for you to feel better about all of this by the time the visit's over. Because I want you to know you can live a really great life with an ostomy. And if you have specific questions about things that you can or can't do with an ostomy, I want a chance to talk about those with you. Next slide. So after surgery, you're in the hospital, we're going to teach you how to manage it. We're going to teach you how to empty the pouch, how to change the pouching system, where to get supplies. We'll get all that set up for you. That's not something you have to do. You have enough going on healing from surgery. When you have questions, or when you're ready to talk about travel or activity, we'll talk about that. And when you're ready to change to a different pouch style, a different manufacturer, if you need to, we'll do that. And you want to work towards resuming activities. If you're going back to work, you want to exercise and get back to your usual exercise, and we hope that you do. When you're ready for intimacy, all those things are things that we can talk to you about. And ongoing continuing education for living with a stoma is important. There's a lot of things available through the United Ostomy Association of America. The different big manufacturers have great education materials. We are a resource for you for life. Next slide. Next slide, please. So talk to others that either have an ostomy or if you are looking at, do I need an ostomy? We can set you up with one-on-one conversations by phone, or if you want to meet in person, to people that live with a urostomy already. I mentioned the United Ostomy Association of America. That's a really good source of online information. There are a lot of blogs and things out there, and you just need to know, you want factual information when you're contemplating this decision of urostomy. There are support groups. A lot of big cities have a support group. There are things like World Ostomy Day that really celebrates ostomy and how well, the beauty of an ostomy is health and longevity. And we at UW and SCCA, we celebrate that along with you because it's super important. Next slide. So there are ostomy related products, and these are just a few. There's a lot out there. So for example, a stealth belt is something your pouching system can be in, and there's many manufacturers. Stealth is just one brand that hold the pouching system close to you. It makes it very discreet as you go about living your fullest life. If you do things, say you're an auto mechanic, and you're leaning against cars, how is that going to impact your stoma? Or say you're an avid hiker. I've had people bring in their packs to say, I want you to put this ostomy site marking somewhere where it won't impact your pack. We can't always do that. If we can, we do, but if we can't, there are things like a stone protector that will allow you to do the activities you want without damaging your ostomy. And then for clothing, there's websites, there's places that you can buy ostomy clothing that are beautiful, that are comfortable, that hold your pouching system close to you. And if that's an interest, we'll help you get connected with those things as well. Next slide. So we want you to be successful with your ostomy, and we want you to be active. We want you to be proactive in your care and your ostomy related needs. Stay in touch with your ostomy nurse forever. Stay in touch with your doctor forever. See us at least once a year. If you are admitted back to our hospital for any reason, we like to see ostomy patients say, you're doing great. Let's just take a peek at your pouching system. Let's look at your skin and see if there's anything that we can optimize. And if you have a concern, please give us a call, ask us. We're here to help. Next slide. So any questions, I'm happy to answer those. Thank you.
Fantastic, Colleen. It's such a, thanks for all that you and your team that do. It's such a great resource for our patients and for us on the surgical side. So rounding out this talk, this session, I want to introduce Dr. Tiffany Chen. I think it's been talked about a little bit already. Dr. Jonathan Chen mentioned this, and Dr. Psutka did too, about just the big operation that we put patients through to do a radical cystectomy. And oftentimes patients have other medical issues as well. And so we are lucky enough to team up with what we call here our medicine consult service to help us to maximize the patient's success and minimize the probability of having complications, but certainly they do occur. So Dr. Chen went to med school at UChicago, a residency at UW, is an assistant professor here, and she's the director of the medicine consult service and a very important team member for us taking care of our bladder cancer patients. So I'll turn it over to her to talk about some of her work.
Hi, thank you so much for having me. Let me just quickly share my screen. Okay. And so we're the perioperative medicine consult service. So who are we? We're actually a group of people. We're general medicine doctors, and we have particular interest in perioperative medicine. We practice in our pre-op clinic and in the hospital as well. So this is sort of our friendly faces that some of you will see. Sorry, I'm just looking at the chat. Who generally sees us and why? So mainly patients who have other medical issues, or if they don't have good functional status and it's not clear why, we're here to help. Our goal is to optimize all your other medical care and medical issues, and both before and after surgery, in order to minimize medical complications, because you have enough other things going on. So what to expect for people that come see us. So we're located in the surgery pavilion here. We do a pre-op evaluation in our clinic. We will review all of your other medical conditions, make sure they're as well controlled as possible. A lot of times your other medical conditions are affected by your cancer and the chemotherapy and other treatments you're undergoing. So we will review those. We'll ask about your symptoms, really from head to toe, to make sure there's not any other underlying medical issues that you may not have been aware of or others may not have uncovered, so that we know what's going on before the surgery. And we'll thoroughly evaluate your medications and adjust them and give you instructions on what to do with them before surgery. Okay. Then we will see you again after surgery. We will come by after. We will help manage your medical conditions while you're in the hospital. We will be encouraging you to move, doing breathing exercises, again, to try and prevent any complications. And also, sometimes things just happen, to watch and monitor for any complications that might happen so that we can resolve them early and intervene on them early. And then afterwards, we will often actually coordinate with your primary care doctor or any other specialist. So if your main person is your rheumatologist or your cardiologist, we'll coordinate the care and make a phone call to them if something happened in the hospital that we feel like they should be aware of, or if there are things that they need to follow up on because we changed your medications or things like that. Okay. So general pearl, so we won't see all of you, but so I am so glad to be here to be able to have a chance to talk with you for just some general pearls for everyone, even those without other medical comorbidities. I know it's hard, I can't even imagine what going through treatment must be like, but trying to stay active and building endurance before your surgery. People who have better functional status, who are more active, tend to do better after surgery. And so it takes about 4 to 6 weeks to build people's endurance. So, even before I see people, I get a chance to do in clinic, here's my plug now to do whatever you can to just do a little bit more than what you did the day before, because you will sort of do better through surgery the more that you can stay active and build your endurance. You already had a talk about nutrition and making sure to eat well. We love, all the colors of the rainbow, but sometimes I hear patients are like, I'm really nauseous or my tastes are off. And so sometimes nutrition looks like a protein shake, but trying to make sure that you're maintaining your nutrition before surgery is really important. And let us know, or other people, if it is a symptom that, like nausea, that is keeping you from being able to maintain your nutrition, because we have things that we can do to help you with that. And have a post-op game plan. This is a big surgery, so I like to talk to people about, like, what's the plan afterwards? Who's going to take care of you? Who lives with you? If there's worry that maybe there might need to be a short stay at like a rehab facility, what are ones near you? Is it worth it to visit beforehand? Who's your people who will help you? Because after surgery is the time for people to take care of you. And, I would reach out to those that can help. And again, we'll see you after surgery, and we'll be your cheerleaders. And here's my plug about trying to mobilize really as soon as we can after surgery, sitting in a chair, walking. We have people to help you. Know that the nurses will do an assessment about, your safety to walk with or without someone in the hospital. So even if you're like, I walk around totally fine at home, they might do an assessment and decide if it's best if there's an aide with you or something, because we don't want people falling in the hospital either. And you might be on pain medicines or waiting from anesthesia. So we definitely want you to get up and to get up safely, because again, you will do better the more that you can mobilize. And you'll get this fun little machine, which we will go over as well in the hospital, but for you to be aware of beforehand, that one of the big complications after surgeries, especially when they're operating in the abdomen, is lung complications like pneumonias and things like that. And so trying to sit in a chair, walk, or use this machine to help open up your lungs are happy lungs and help reduce complications after surgery. And so that's my plug and sort of who we are. Thank you so much for having me here, and I'm around. I can stick around for questions of the Q&A also.
Thank you so much, Dr. Chen. Very important data, and I think it's important information for our patients and families how to optimally prepare for a surgery, how to follow up after that. So thank you so much for sharing. And if there are questions, I may ask you to take a look in the chat room in case questions pop up in the next few minutes. In the interest of time, we know we ran behind. We were too optimistic to put all the information together in 2.5 hours. But it's so great material, it's hard to cover everything within time. We'll try to move on. Again, thank you all the speakers for amazing discussion so far. We'll move on to the next session. And I'm very excited to present and introduce two great additional colleagues, Dr. Andrew Shea, great friend and colleague. He's a physician at Seattle Cancer Care Alliance. He's an associate professor, Division of Medical Oncology, at the University of Washington, and also associate professor at Human Biology Division at Fred Hutchinson Cancer Center, also in the Clinical Research Division there, as well as Dr. Ming Lam. Dr. Lam is a research associate professor, and she's leading research efforts in the GU Cancer Research Lab under the Department of Urology at the University of Washington. So Ming and Andrew, you can take it away.
All right, I'm going to share my screen right now. Do you guys see my screen? Do you guys hear me?
Absolutely.
Yes.
Perfect. Well, I want to thank everybody, Ritu for putting this together, as well as Dr. Wright and Dr. Grivas. And I'd like to thank you for being here today. So my name's Andrew Shea. I'm a physician scientist. I see patients about 10% of my time. 90% of my time I spend studying cancer. And really what we're charged with today is to kind of give you a very brief overview on what it is to be studying bladder cancer within the Pacific Northwest. I think this is a very special place. This is a picture that I took off of Whidbey Island. I think you would all agree with me that really there are very few places in the world where you could get a picture like this. And I want to argue today that there are very few places in the world that you could do research like this. In the Pacific Northwest. And first, just to kind of frame what we're dealing with here, we're dealing with bladder cancer. And that's why we're, more than 120 strong on this call today. It is a terrible disease affecting both men and women. And there are way more deaths than there should ever be for any type of malignancy, at about 17,000 estimated in 2020. It's also a very expensive cancer to treat. And there are a lot of discussions today on the intensiveness of the treatment for this disease. I want to say, though, that over the past few years, there have been a lot of developments in terms of therapies available for patients, and this is because of the tremendous amount of research that's been done. But there's still a lot we don't know, and in particular, it's the more aggressive form of the disease when the cat's out of the bag, when it's outside the bladder, what to do, how to treat these patients, and then, of course, what are the next therapies, what are the next innovations. This is a big area of research that needs to be tackled. And just to kind of give you guys a flavor of what we're exactly studying, we're really trying to understand this tissue right here. So this is a picture of what we call urothelium. And this is where, your body guards against urine getting into the rest of your body, but it's also the place where bladder cancer can start. And so we're really trying to understand the biology of what makes this tissue tick and how this gets messed up in the context of cancer. Now, why do I say I think we have something very special here in the Pacific Northwest? Well, because we have a group of like-minded individuals who are shareholders investing our lives, our time, our mental energy into studying bladder cancer. And this is a picture of us taken actually a few years ago. We call ourselves the Bladder Cancer Group, otherwise known as BCG. And this was us a few years ago at one of the national conferences. This is what a research lab looks like. This is my research lab here at the Fred Hutch. But right here is a list of all the names of people who are studying various aspects of bladder cancer here at the Fred Hutch and the University of Washington. And I also want to highlight that this group has grown. Just over this past year, we've included folks like Dr. Psutka, Dr. Ha, and Dr. Hafner, who are now integrating into the group. And so this group is actively growing over time. And one thing that we all come together with, and Dr. Ming Lam, who's going to be talking after me, that we come together and coalesce around is this special program that we've developed called the Bladder Cancer Rapid Autopsy Program, where we're really answering the central question. If you're going to really understand the disease that hurts patients, you really need to look at the tissues that hurt patients. And I'm not going to go into the details of this because Dr. Lam's going to do a great job talking about this right after me. But I do want to highlight that just over the past 5 years, this program has grown tremendously. And not only that, but it's allowed us to make contributions into the scientific field and also garner funding to continue to grow this program through organizations like the Department of Defense, where we've gotten 3 research grants to study bladder cancer in the Pacific Northwest that I think will actually not just benefit our local regional area, but also the entire world. I want to give you guys just a quick anecdote of what it looks like when bladder cancer research is successful. I do think that we need sustained funding to accelerate the pace and reach of bladder cancer research in the Pacific Northwest. My laboratory itself does this kind of work. Over the past few years, we've been applying for grants. And this past year, we were able to get a large grant from the Kleberg Foundation. And this was in part because we had this rapid autopsy program. We were the only application out of quite a few that was funded for bladder cancer research. And this was a national search for research projects that they wanted to fund. This is a lot of wording, but I do want to say that even despite the fact that we've been through the worst pandemic that we've seen in 100 years, this work has continued to move on. And I'm very, very excited by the fact that through things like this type of funding or the DoD and Bladder Cancer Action Network, this group that we formed has been able to galvanize together around this idea of really understanding bladder cancer research better, bladder cancer and how it starts, begins, and causes problems in patients better. These are just some diagrams I wanted to show you that in terms of research projects, we have many of them going in the laboratory, but I really want to highlight the fact that you can't work in a bubble. And really what you need to do is collaborate. And we have many strong collaborations. These are just some examples here with Dr. Wright, Dr. Lam, and Dr. Ha. This is the last slide. In this coming year, despite the fact that we are in the middle of a pandemic, this has not stopped the pace of the research in the Pacific Northwest. We are in the process of generating a comprehensive integrative genomic data set using this tissue samples that we've garnered. And this is made possible because of philanthropy. This is made possible because of grants that we've gotten. And it's made possible because we have people who are committed to this. We are delineating how bladder cancers actually form. And we're using this through mouse models, through human tissues, which is very exciting work. We're trying to understand what makes bladder cancer variants different from each other. And this is going to be really important for us to be able to eventually therapeutically target these things. We're studying very novel things like mRNA translation and how different types of drugs might be able to stop the growth of bladder cancer, which we're very excited about. We're also obviously engaging drug companies and also engaging patients because of patient-centered outcomes research that we're working on, as well as new clinical trials that are going to be coming online at the SCCA and the University of Washington. And of course, we're constantly on a quest to continue to build the program and developing group grants together. So I'd like to thank you very much for this time. And I'd just like to just let you know that, we do not work, in silos. And if you guys have questions about bladder cancer research, please do reach out because we're more than happy to engage. Thank you very much and take care.
Thank you, Andrew. Fantastic summary of our efforts. It's such a pleasure to work as a team. And I think the team spirit is definitely a huge part of that. Dr. Lam, you can take over.
Cool, you can see my screen.
Yes.
So, good. So, hello, everyone. Thanks to Dr. Grivas and Dr. Wright in inviting me to provide a research talk on this bladder cancer program. So I'm happy to share with you what's going on in terms of research as a broad picture. And more importantly is our biospecimen effort in terms of accelerating the research going on in the Seattle. So I do have a couple of research funding to disclose. And as Dr. Wright mentioned earlier, that we do have a very special bladder cancer rapid autopsy program happening in the Seattle. So this is a very dedicated program for bladder cancer research that will allow patients to donate their body for bladder cancer research after they pass of the disease. So this bladder cancer rapid autopsy program actually started in 2015. That is provided by seed funding from Howard Cohen Foundation, as well as the Seattle Translational Tumor Research. So this program basically is allow us to acquire very precious metastatic disease that otherwise other groups or people are not really able to acquire. For us to understand what's happening in this very aggressive stage of disease. This program is, so basically what happened is the patient will be, eligible patient will be consent for rapid autopsy. So once the patient passed, our teams is standby 24/7 whenever we receive a note saying that there are patient consented. So the patient passed away, immediately we will receive a phone call and the team will be assembled within 2 hours. After the patients pass away, the body will be transported in and autopsy will be immediately performed. Then we will acquire as fresh tissue as possible, as good quality tissue as possible to allow us to understand the biology underlying all these metastatic sites. So what will happen is we will have the rapid autopsy started with all the metastases sampled. Then we will split into 2 teams. One team is process the tissues right away, let us for biological exploration. And the other team is immediately implant this patient tumor into mouse to allow us to let the mouse carry the tumor so that we can perform drug testing afterwards. Then the patient will be prepared for their funeral home of choice and all the transport will be on us. So far we have performed 20 autopsy and over 350 specimens collected. This is a really large repertoire of specimens that allow us to systematically characterize this disease. And if you have a snapshot on these 14 patients that has performed in our autopsy program, every single color is their metastasis involvement. So you can see from this particular patient has 3 metastatic involvement involving liver, lung, etc. to a patient that have like a rainbow color, multiple organs in the site are involved when he passed away from his bladder cancer. And we were able to develop patient-derived xenografts of this patient for drug testing. So patient-derived xenograph is actually a mouse human tumor implant into the mouse so that he carried the tumor. For us, we can go through sequencing, make sure this tumor have the same mutation of the originating patient tumor so that we are confident that we are going to target this drug for this patient. So this patient-derived xenograft was supported by a Cohen Foundation Cancer of the Bladder. That's why it's named CoCap series. And we have 9 PDX developed so far, and they are the first series that representing bladder cancer metastasis in the world. And we, of course, we also have organoids and 2D cultures that allow rapid drug screening. So this is a snapshot. What are we going to do with these different metastases that we acquire? Now we have over 60 specimens, and we are going to perform a very comprehensive genomic multi-omics analysis on all these patient tumors, trying to understand what is actually happening in the patient. So we perform mutation analysis, gene expression, epigenetics, protein, and more recently, this concept of tumor interaction with the tumor microenvironment that we are going to devote our energy to study. Because tumor doesn't really live by its own. It needs support from its microenvironment, just like if you migrate to Asia, you need to learn the local language in order to thrive. So we are going to target the tumor and the tumor microenvironment together. So this is a very, very like important finding that well, we find out recently is that there's actually druggable target exists despite the patient die from bladder cancer. So this is what we found in the autopsy finding is patient number 1, 2, 3 have different metastatic site involvement. Patient number 1 has 3 metastatic site involvement in the liver omentum plus the bladder. He still have actionable targets, but he didn't, unfortunately, didn't survive through the FGFR being approved. So if he's still alive, he will be eligible for these targets. And so does these 2 patients. So our vision for bladder cancer, this is the last slide, where now still few treatment exists, but we are poised to explore more treatments through our clinical specimen program, because this is the only resource that we can develop to really allow us to understand what's happening in the patient, what's happening in the clinical metastasis. And we really want to empower patients to engage in research through this clinical specimen program. And we have our expertise in place to do multi-omics sequencing to define the most lethal type of metastatic bladder cancer. And at the same time, we are developing the cutting edge method in treating the tumor and its tumor microenvironment as an ecosystem. So thank you for your time, and we're happy to take any questions.
Thank you so much, Dr. Lam and Dr. Say. Wonderful presentations in a short amount of time. And I just want to highlight once again the team spirit. Such a pleasure to work as a team to try to tackle bladder cancer and urinary tract cancers, all the way from the basic science, you know, the bedside, as we call it, understanding the characteristics of the cancer, the causes and the different, you know, underpinnings, as you both said, all the way to clinical trials. And I would like to ask both of you to keep an eye on the chat room in case folks have questions. At this point of time, I will ask Ritu to post one slide. I will try to make us time here. I'm not going to spend 10 minutes talking about clinical trials, but I'm going to send this slide to all of you. And I just want to pass a simple message. As Dr. Alam and Dr. Say and all the other speakers talked about, research, and Dr. Montgomery made this point, is a vital and essential component of patient care. The National Comprehensive Cancer Network, so-called NCCN guidelines, make a point that the research and clinical trials should be considered as a standard of care. It's part of our option portfolio, and we should talk and we must talk to our patients about available clinical trials. The clinical trials aim to help the patients, so they have the intent to help the particular patient in front of us, but also aim to help the society and help us become smarter and define avenues, you know, for development of the next standard of care and develop new therapies. And I can share with you, in the last few years, I will just say I'm so honored to work with a great team locally here at our institutions and internationally, and be part of teams that actually change the clinical practice, develop new standards of care through innovative and practice-changing, transforming, as I call them, clinical trials. So my message to you is please ask about clinical trials, talk to your provider, talk to your team. There's always a time and good time to talk about clinical research and translational research. And our goal is to cover pretty much the entire spectrum of this disease, all the way from the early stages that Dr. Gore covered, the non-muscle invasive bladder cancer, what we call localized bladder cancer, the muscle invasive bladder cancer, and the metastatic disease when the cancer spreads beyond the urinary tract neighborhood or environment. And we have multiple clinical trials open at the CCA, University of Washington, and Fred Hutch, trying to cover every single scenario if we can. Obviously, there are scenarios that cannot be covered, but our intent is to cover and serve the needs of all our patients. So we'll share the slide with you to save us some time here. And please, if you have questions about our research program, please reach out to us, Dr. Wright, myself, Ritu and Cody, and we're going to get back to you if you want to even get a tour in one of our labs. We did that with some patients in the past. I'm sure our colleagues will be happy to do that and also talk to you about our research in more detail on one-to-one fashion if you have interest. And talking about clinical trials, I think it's a great segue here. in order to make the point that this regard urology, oncology, medical oncology, radiation oncology, and as I mentioned, all the aspects of care in this continuum from early stage to late stage of this cancer. And of course, we love the partnership with Howard J. Cohen Foundation and the Bladder Cancer Advocacy Network, the Beacon. I have to practice always to pronounce this correctly. It's, BCAN, but we pronounce it as Beacon of Hope or Beacon of Light. And I can tell you that this is a great pleasant honor to have Stephanie and Morgan today from the Bladder Cancer Advocacy Network. They're great partners across many, many years. I know work with them in the last 7 years myself, and Dr. Wright, the same thing. We organize walks every year. We work with them in educational sessions, and it's such a pleasure to work with them. They have a clinical trial dashboard and many other functions. This is a picture of the booklet and brochure they can provide for free to our patients and families. And without further delay, I will pass the microphone to Stephanie and Morgan to say a few words. Thank you for joining and thank you for sponsoring. Can probably have Stephanie take over.
Are you able to hear me?
Yes, we can. Thank you. I think you're muted, Stephanie.
Okay.
Now we're good.
One second. If I could just share my screen, 1 second. Okay. Again, I'm the Director of Education and Research at the Bladder Cancer Advocacy Network, and we work very closely with everybody, the team at the Seattle Cancer Care. It's a phenomenal group of people, and you are all so lucky to be able to have your care through them, because as you saw all morning, this has just been a phenomenal spectrum of everything you could possibly imagine. So it's really exciting to just share a few things. Obviously, the Bladder Cancer Advocacy Network was started in 2005, and we do raise awareness about the disease. We do education. We want to help you to be the most informed patients that you can be when you go into the doctor's office. We do support research, like the research that Dr. Sarah Psutka had mentioned. She won one of our Young Investigator Awards, and we advocate politically on the Hill and also in your state when there are issues that pertain to the bladder cancer community. And I think what's really important is to remind you that everything that we do is free. I encourage everyone to visit our website, bcan.org. And there you will see all sorts of expert videos, like the one that we did 2 days ago with Dr. Wright and Dr. Grivas talking about maintenance therapy. And there's others by Dr. Psutka and many others that are there. And also, we are now launching some podcasts. I put in a podcast in the chat feature about our recent podcast regarding COVID vaccine and bladder cancer patients and what you should know. And we'll be able to send you this little list of everything that Beacon has. It's just a simple handout, very similar to what the booklet is with our bladder cancer basics. And again, everything on here is free of charge, and we'll make that available to Ritu to send out to everybody later on today. And also, I just wanted to let you know that, we have a number of live programs. You can be sure to look out for our summit in October for patients and their family. And this is part of our Coffee and Conversations program. We're helping to sponsor this. And for those who provided their email, their street address, we'll be able to send you one of our phenomenal Beacon travel coffee mugs. And we also have a special booklet of tips for caregivers. So if you have any questions, Morgan's going to drop her email in there. You can send her a note and she'll be happy to get any of those things out to you. And I just wanted to remind everybody, it'll be here before we know it because we're all looking forward to warmer weather. May is Bladder Cancer Awareness Month. And one of the phenomenal programs that we have coming up at the end of May is our Ask the Experts program, where you'll get to actually hear Dr. Sarah Psutka talking about her research and research by Dr. Kent Mao, which is all funded by this particular kind of event, this Ask the Experts. On May the 1st, I'll tell you a bit about that in just a second. I'll invite you to join the Walk to End Bladder Cancer. And something unique this year that we're doing for the first time is you can nominate your very own Beacon of Hope. So if you go to beacon.org, Bladder Cancer Awareness Month 2021, you'll get all of those details. And I do encourage you to join us for the walk. It will be a virtual walk, so you can walk from anywhere. I miss coming out to Seattle to be out there and walking in that beautiful park where we walked for so many years. But this is kind of nice in that you can do it from anywhere, and all the information is there on the website. So thank you. And if you have any questions about Beacon, be sure to drop them into the Dropbox and we'll be happy to answer them for you. Thanks so much for having me here.
Thank you,
Thanks, Stephanie. It truly is amazing how much Beacon has done for us and for our patients. Just an unbelievable resource. So thank you for all that you, Morgan, and the whole group does. Started originally by a survivor family. It's just wonderful. So Diane. Well, we are going to switch now. We're going to try this. We're going to have a breakout session. So it's going to pop up on your screen, whether you're on a phone or on the computer, and just kind of play around. We should be doing that out the cuff too. It's such a huge part. We're learning so much more, and having you two on the team is just phenomenal. So I think Rita, do you want to show up our last slide? Again, Dr. Grivas and I appreciate everyone taking the time to be here with us today, and all of our speakers. We really would like feedback as well. We plan to continue to do this annually. We hope to be in person next year, but ideas for future topics, future talks would be very appreciated. So there is a link that we would like you to, if you get a chance to fill out and give us all some feedback so we can improve for you and for the next participants. Stephanie talked about from Beacon, the upcoming walk. Here is our team, the UW-SCCA Urologic Oncology team. So please go and join our team online. We'll send you the link for that as well too. And we can get out and walk and raise money for the Beacon organization and all the things they do for all of us. We will send around a link to the talk and to the different links that we discussed, and there's more coming in. We'll keep doing it. So I hope you all have a wonderful rest of your weekend. Thank you for participating, and we will all continue in this fight together, and congrats on survivorship.
Thank you so much. As Jonathan said, both of us were super excited to spend this morning with you. Thank you so much for all the participants, patients, families, caregivers. You guys are the reason for us to be here and for us to keep fighting, as Jonathan mentioned, our good fight against bladder cancer and urinary tract cancers, and we'll keep this fight on. Thanks all the speakers, the sponsors, Seattle Cancer Care Alliance, Cody and your team, Carrie, for all the support. And I want to make sure I don't forget to thank everybody, but this is a huge team effort, and we'll continue this in the next months and next year. Join us for the Bladder Cancer Advocacy Network walk. And if you have questions, please follow up with us. In any questions you may have, we're here to help and support you. Have a wonderful rest of the weekend. Thank you again for joining us.
Thank you all for putting this on.